When a belief screening indicates a client likely has a substance use problem, the clinical process shifts. We move past the simple yes or no question of whether a problem exists and enter a much broader investigative phase. This is the comprehensive, strengths-based biopsychosocial assessment. It is the deep map that guides all subsequent decisions, exploring the true nature and severity of the client's condition. We start by gathering a detailed substance use history. This means documenting the specific substances used, the patterns and routes of administration, the exact age of onset, and the direct consequences of that use. But addiction does not happen in a vacuum. The evaluation must capture the client's systemic medical and psychiatric history, alongside their family background, developmental milestones, and any history of trauma. From there, we map the external socio-environmental realities. We look at current legal status, educational and vocational background, and the stability and safety of their daily living environment. Finally, we document the internal and personal dimensions, the cultural and spiritual context the client operates within, their inherent strengths, and crucially, how they perceive their own problem and what goals they have for treatment. A simple positive or negative screening score cannot capture this level of reality. Relying on a single metric obscures the complex web of needs and resources that dictate whether a specific treatment approach will actually work. To organize this vast amount of information, clinicians often use standardized structural frameworks, like the Addiction Severity Index, or ASI. The ASI structures the data by measuring problem severity across specific domains. It starts by quantifying challenges in the client's medical status, their employment and support structures, and their alcohol use. It then expands to measure severity in drug use, legal issues, family and social relationships, and psychiatric status. The result is a multidimensional profile of the client. By design, the ASI refuses to reduce a human being to a single number, instead highlighting exactly which areas require the most urgent intervention. Gathering this extensive profile requires the right clinical posture. This is a collaborative exploration, not an interrogation. Utilizing core counseling conditions, empathy, and active listening builds rapport and client engagement at the exact same time the data is being collected. This combination of rigorous structural organization and empathetic communication ensures the data is accurate, while simultaneously preparing both the client and the clinician for collaborative treatment planning. Competent assessment rests on two defining principles. The first is that the evaluation must be strengths-based. While documenting the severity of the illness, the counselor deliberately identifies the client's available resources, coping skills, community supports, internal motivations, and any prior periods of successful recovery. If an assessment focused solely on deficits and pathology, it fails to record the exact tools the client needs to get better. Treatment relies on leveraging existing strengths, making a purely problem-focused map structurally incomplete. The second defining principle is time. Assessment functions as a continuous feedback loop that adjusts to the client's shifting status throughout the course of treatment. As a client undergoes withdrawal, achieves medical stability, or begins to make psychological progress, their clinical profile shifts. Symptoms that appeared severe on day 1 might resolve entirely, while new challenges emerge on day 10. By continually re-evaluating these domains, the clinician ensures the interventions remain perfectly aligned with the client's current reality, rather than treating a version of the person that no longer exists. This stream of updated information flows directly into the diagnostic summary, forcing the treatment plan to adapt and evolve in real time. This ongoing, thorough evaluation ensures that every clinical intervention remains anchored to the client's actual progress, forming the structural basis for the entire treatment strategy. A thorough assessment fails if data is invalid. Instruments must be calibrated to the client's cultural context. A tool accurate for one demographic may produce skewed data elsewhere. Beyond language, local idioms and community norms can easily derail a standard questionnaire. A culturally responsive counselor bridges this gap by sourcing appropriate language and appropriate literacy materials, utilizing qualified interpreters, and structuring their interview questions in a way that resonates with the client's lived experience. Crucially, the counselor must interpret the client's responses through the lens of the client's own cultural norms, filtering out the counselor's default assumptions. failing to adapt to the client's context guarantees inaccurate clinical findings. Worse, it ruptures the very engagement and trust that the entire assessment process relies upon. Because screening and assessment generate highly sensitive personal information, the data is protected under strict legal frameworks like HIPAA and 42 CFR Part 2. Before a counselor can solicit records from a hospital or provide updates to family members, courts, or employers, they must navigate a rigid sequence to obtain appropriate, valid consent from the client. The counselor must explicitly explain how the information will be used by these third parties, and when communicating outward, they are mandated to disclose only the absolute minimum data necessary to satisfy the request. Clients are also briefed on their exact rights and the explicit legal limits of their confidentiality from the moment the assessment begins. Securing this map of the client's life is a legal requirement and an ethical mandate. Mishandling this data can cause severe, tangible harm to the client's personal and professional life. During this deep dive, the assessment frequently uncovers severe conditions like active psychosis, significant suicide risk, or acute medical emergencies that lie strictly outside a chemical dependency counselor's scope of practice. Recognizing these clinical boundaries and successfully passing the client to a higher level of care is a core professional competency. It is a sign of clinical precision, not a failure. When the presenting picture indicates a coexisting condition the program is unequipped to treat, the counselor has an absolute ethical responsibility to initiate an external referral. The assessment process forces clarity on exactly what the facility can handle safely. Acting decisively on that distinction ultimately protects the client's life and chances at recovery. The entire architecture of intake relies on keeping these functions distinct. Screening is the brief, focused process that determines if a problem likely exists and if the setting is appropriate. Assessment is the deep, comprehensive gathering of severity, strengths, and needs. A positive screen functions exclusively as a signal to look closer. It serves as a bridge to a full assessment, rather than a justification for a diagnosis or a specific treatment choice. Validated tools like the CAGE, Audit, or the Addiction Severity Index provide the structure, but their scores must be interpreted strictly as indicators of clinical risk, rather than definitive verdicts. And the comprehensive assessment itself only succeeds when it is treated as a continuous, culturally responsive process, bound by strict confidentiality and a clear understanding of the counselor's clinical limits. When this foundation is constructed correctly, it produces an accurate diagnostic summary and a highly effective, workable treatment plan. When it is rushed or built poorly, it undermines the client's entire course of recovery before it even begins.